potential travels first along the surface of sarcolemma, which is the excitable membrane that surrounds those cylindrical structures known as myofibrils. Then the action potential travels through T-tubule system, which penetrates into the fiber. And then the arrival of action potential causes calcium to be released from the sarcoplasmic reticulum, which finally leads to muscle contraction. Now, let's see all these steps in action. So, action potential causes release of acetylcholine, channels open, sodium goes in, triggers another action potential, calcium gets released, and muscle contracts. It's that easy. Now, neuromuscular blocking agents work at this junction here by interacting with these nicotinic acetylcholine receptors. We can divide these agents into two groups. First, non-depolarizing agents, and second, depolarizing agents. For all of you who need a quick review of membrane depolarization, I strongly encourage you to watch my short 3-minute video about action potential. So let's talk about non-depolarizing agents first. These agents are competitive antagonists. They bind to acetylcholine receptors, but they don't induce ion channel opening. What that means is that they prevent depolarization of the muscle cell membrane and thus effectively inhibit muscle contraction. In clinical practice, these agents are used to facilitate mechanical ventilation and tracheal intubation, as well as to increase muscle relaxation during surgery, which allows for lower doses of general anesthetics. Generally speaking, non-depolarizing agents are not absorbed from GI, and that's why must be injected, usually intravenously. Time to onset of action is rapid, usually less than 2 minutes. Once administered, these agents paralyze small, fast-contracting muscle first, that is eyes, face, fingers, then larger muscles of neck, trunk, and limbs, and lastly diaphragm. On the other hand, these muscles recover in the reverse manner, that is diaphragm first, then limbs, trunk, and so on and so forth. The choice of an agent typically depends on the desired onset and duration of the muscle relaxation. And just a side note, a clinical duration of these agents is a time measured from administration to recovery of 25% of baseline muscle strength. Now, some of the most widely used agents in this group are the following. Cis-atracurium, which has clinical duration of about 90 minutes, pancuronium, which also has clinical duration of about 90 minutes, rocuronium, with clinical duration of about 40 minutes, vecuronium, which also has clinical duration of about 40 minutes, and lastly, atracurium, with 40-minute clinical duration as well. Now, when it comes to side effects, atracurium causes histamine release, which results in fall in blood pressure, flushing, and bronchoconstriction. It also has toxic metabolite called laudanosine, which can provoke seizures, especially in patients with impaired renal function. This is why atracurium has been largely replaced by its isomer, cis-atracurium, which fortunately is much less likely to produce the same adverse effects because its metabolism is independent of hepatic or renal function. Therefore, cis-atracurium is often used in patients with multi-organ failure. Now, vecuronium and rocuronium are metabolized by liver, so their action may be prolonged in patients with hepatic dysfunction. But overall, they are safe and have minimal side effects. Lastly, pancuronium is excreted unchanged in urine, and one of its main side effects is increase in heart rate. Now, let's move on to depolarizing agents. So, depolarizing agents act as a acetylcholine receptor agonists. They mimic the acetylcholine, however, they are much more resistant to degradation by acetylcholinesterase, and therefore produce persistent depolarization. Now, the only depolarizing agent that's still used in clinical practice is succinylcholine. So, succinylcholine binds to the nicotinic receptor, and unlike the non-depolarizing agents, it actually causes the sodium channel to open, which results in membrane depolarization. Now, because succinylcholine is resistant to acetylcholinesterase, it causes prolonged depolarization, which leads to a transient fasciculations and finally flaccid paralysis. This is referred to as phase 1 block. Now, eventually, sodium channel closes and membrane repolarizes. However, due to continued stimulation by succinylcholine, the receptor becomes desensitized to acetylcholine, thus preventing formation of further action potentials. This is referred to as phase 2 block. Now, succinylcholine has a rapid onset of action, and therefore is commonly used to facilitate rapid sequence endotracheal intubation in critically ill patients. It's also sometimes used to provide adequate muscle relaxation during electroconvulsive therapy. Following intravenous administration, succinylcholine causes complete muscle relaxation within 1 minute. The effects typically last up to 10 minutes due to rapid redistribution and hydrolysis by plasma pseudocholinesterase. And that brings us to adverse effects. In patients deficient in plasma pseudocholinesterase, or patients who have genetic variation of this enzyme, succinylcholine can lead to prolonged apnea. Next, prolonged depolarization caused by succinylcholine leads to continued flow of potassium into the extracellular fluid, which can result in hyperkalemia. Now, in patients with normal potassium levels, this is usually not a big issue. However, in those with elevated potassium levels, for example due to burns or large tissue damage, succinylcholine can cause serious EKG changes and even in severe cases, asystole. Lastly, in genetically susceptible patients, succinylcholine can trigger a rare and potentially fatal condition called malignant hyperthermia. Symptoms of malignant hyperthermia include severe muscle contractions and dangerously high body temperature that can reach as high as 43 degrees Celsius. And with that, I wanted to thank you for watching, and I hope you enjoyed this video.